A lot of audit challenges or billing audit challenges for the pediatric side are electronic medical records. There are some quirks in there. There's some benefits, in fact, that people use templates. Well, sometimes those templates, if they're not used correctly, make it look like you're using canned notes and that the visits are not unique and they don't have unique information for each patient visit. And so that's a problem. There are NCOs who are zeroing in on that. Now, you got to understand for these auditors, whether it be a problem with your notes, and usually it's in the documentation, it's in the clinical documentation that they find fault. So in those situations, the reviewers, once they get to the thing that renders the claim non-payable, they stop. If you have a pattern in your clinical notes, such as you're using templates for everything, and the templates are the same from visit to visit, and they declare them all invalid, well, they don't have to really look any further. It's done. It's an easy review for them. It's what I call the low-hanging fruit. I mean, they've gotten their low-hanging fruit. They're done. With that case, they're done for the day. So that's the challenge that we're looking at right now. I'm optimistic, but we haven't gotten a resolution yet, so I'm not really sure what that's going to look like. Now, on the YG side, we have on the pediatric private duty nursing side, they are looking at certain modifiers, that are, a particular modifier that's used for vent patients. They have been auditing pediatric private duty nursing providers for the past several years. You'll see that with Medicaid a lot. I think a lot of times what they do is they get information from their year-end report. Their state fiscal year ends on August 31st every year. And so by the time the fall rolls around, they're starting to see what the numbers for the previous year were like. And if there was utilization that was really high in one area, that gets a lot of scrutiny, especially if it pops up. If there's a sharp rise in utilization in a particular year, that gets a lot of scrutiny. And so then they spend the next year and further looking at that particular service. So they've been looking at this particular modifier, and what they do in these situations is they develop one way to review these and they stick with that way. It's like they learn how to make a box and they duplicate that box. And it makes sense. I mean, you're dealing with the same set of facts in each case.
But by God, don't let the provider use a template.
Exactly. But they exactly, that's this very same thing. They are basically duplicating the last investigation or review they did. And sometimes they make the assumption that they're the same, and they're not. But I mean, the one provider is the same as the other, and they're not. There are a lot of similarities, but they are all very, very different. Even ones in the same field. One pediatric private duty nursing service provider is very different from another. They're different. Well, I see the differences. I don't know, but maybe other people don't. They see just the similarity. But that is one of the things that we're struggling with on that end. I have several cases that are in the works. We don't know where this is going because we're still waiting. I'm waiting to hear a good reason from OIG for my clients why some of these should be denied. We haven't heard that reason. We're still waiting on that. We know it's coming, but I'm not sure. And the reason I say that is with this very subject, what I've heard from OIG staff, things that they find don't make sense, like orders not signed or a lack of orders for ventilation, and they're using the modifier. And this is a very heavily regulated, and there's tons of oversight with pediatric private duty nursing. There's prior authorizations for one, so they couldn't even provide the service and bill for it without an order. So there are little things like that I am just really curious how it plays out.